The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
The question relates to a 10-year-old, 62-pound boy on a gluten-free, casein-free diet. I saw information recently that indicated that high doses of calcium may be linked to inflammation. If that's true, how do you balance the need for calcium supplementation for bone development with the risk of inflammation? For a child of that age and weight who gets very little calcium from food due to texture aversions to vegetables and other persistent feeding issues, what level of supplementation do you think is appropriate?
That's a rather complex question, and there are multiple layers that I would really want to think through and about. I think there is a little bit of evidence out there that indicates high-dose calcium does contribute to inflammation, and that's certainly something we don't want to do with the children that we serve. But for the things I would be thinking about in this situation are, how do we get those foods in that the child is food aversive with? What can I do from a therapy perspective to try to make that happen? How can I use a whole food supplement that would contain calcium in a whole food basis in a more natural and synergistic approach than supplementing strict calcium? And third, I would really want to do the nutrient analysis and see just how much calcium is going in every day, because as this child enters puberty, I'm going to want to be monitoring calcium, magnesium, vitamin K intake, and if we don't have levels that are sufficient to support, I guess, both the growth and bone density that we'd like to see in that time frame, we'd want to be thinking through and problem solving a way to support that adequately. And if there's negligible dietary intake, we would probably want to be using a combined product that offers a minimum of 600 milligrams of calcium in a fairly absorbable form every day, but also includes things like strontium, boron, vitamin K, and magnesium in either a 2-to-1 ratio, a 1-to-2 ratio with calcium up to a 1-to-1 ratio with calcium. So I hope that helps a little bit.
I have a question here about potatoes. It says, potatoes have a history of being bad. Are there health benefits for recipes that call for sweet potatoes?
That's a good question. I think that as a carbohydrate, potatoes in general, white potatoes, are not the best source of both calories and carbohydrate intake. You can substitute with sweet potatoes in many different recipes. You can also look at things like winter squashes and use traditional recipes that you would be using a white potato with and use winter squashes or a sweet potato instead, because those are rich in things like vitamin A and other nutrients that we'd want to be getting in.
Okay. How much is too much melatonin? Will I be on this forever?
So more and more research is coming out about melatonin use every day, and melatonin is really something that traditional practitioners are beginning to be more and more comfortable with use of on a long-term basis, and also for numerous different issues and concerns. So, for example, there's just been some research in the past 18 months, I think, on melatonin and its use in GI disorders. And for those of you who have children with GI concerns, we are using melatonin now more and more to support sleep, but also to support GI status. And so we really start low with melatonin support to see what our threshold for minimum treatment is, but the most recent research uses up to 6 milligrams in children once a day. To the question of whether or not it's an ongoing dose that needs to be used forever, I think that depends on what improvements you see in sleep, behavior, and GI status. Many physicians are now recommending the use of low-dose melatonin on an ongoing basis just to support the GI tract. And I think the early research that we had from 10 or 15 years ago that spoke to not, no data supporting long-term use of melatonin, and therefore it could be problematic. I think we're everyone's more comfortable with long-term use of melatonin if it's needed. So I hope that answers the question.
The next question, if my child responds well to a gluten and casein-free diet, how long will he be on it until he can eat these foods again?
Totally depends on the child. There are so many factors in play in making a decision about which diet to begin for a child and also how long it should be maintained that I can throw out some of those factors for you to think about right now, and that would be things like, is there a celiac diagnosis or not? If a child has a celiac diagnosis, I would say gluten-free for life, possibly casein-free for life, because we are learning that children who have celiac are also quite responsive to dairy proteins as well. If you have a child who has severe gastrointestinal issues and you implement a gluten and casein-free diet to address that, and the child is less symptomatic or asymptomatic with the introduction of the diet, I would say to you that we recommend a minimum of 3 months to see if a child is responsive to dietary intervention, a minimum of 6 months really once that is maintained so that we can trial reintroduction of foods. If you have a child who doesn't really have GI symptoms and does not really evidence any response to removal of those proteins, I would say you're safe to start reintroducing those proteins and looking for other answers at the 90 to 120 day mark.
My son has been on the diet for several months now with positive results. He recently ate a hamburger bun and there has been no regression. What does that mean?
That could mean a number of things. One, it could mean your child is not behaviorally gluten responsive, or your child does not have immediate gastrointestinal response to gluten. It could also mean that your child needed the removal of those proteins from his diet, and when you start adding gluten back in on more than one occasion, so this accidental exposure, if you keep using it, we've seen over time there are children who don't have a dramatic response to an accidental exposure, but in fact when that food is layered back into the diet over time, whether it's 10 days or 2 weeks or 2 months, parents will note a gradual response or a gradual regression in both GI symptoms and also behavior.
All right, next one. Can a child's diet really have an effect on autism or other spectrum disorders? My 5-year-old daughter is an eater. She's growing fine and healthy, but many people say that changes in her diet may have direct benefits for behavior. How does diet affect behavior?
We're learning more and more about how diet can affect behavior. We've talked a little bit about gluten protein already on this call, but we haven't really talked about food additives, dyes, and preservatives. There's something called the Feingold diet, which was developed a number of years ago now in the 1970s that looked at the elimination of all of these artificial ingredients in food, and we have evidence that some children are responsive to those artificial ingredients, and when they are removed, their behavior improves. We also know there are a couple of small research studies out there that tell us even children who lack any sort of diagnosis have higher behavioral scores and fewer problems when they are not exposed to artificial ingredients as opposed to when they are. So we know that those ingredients do affect behavior of all of us. I have a colleague who likes to laugh and say, you know, if anyone says what you eat can't or what you drink can't affect behavior, think about alcohol as the example there. So.
Okay, here's another question about melatonin. This person wants to know if melatonin is supportive of the GI tract.
Yes. The short answer is yes. Serotonin is a precursor to melatonin. And it's a complex pathway that involves the gut as much as it involves the brain, honestly. And that's why I mentioned people are starting to supplement melatonin for GI support as well. So I think that if you look at the literature, that it's just emerging in how we understand the role of serotonin and melatonin in the gut, but we do know it's important and we know it's there.
Okay, and do you have any insight about the use of oxytocin with children on the spectrum? I'm reading more and more research about how that bonding hormone is generally low. Do you have insight?
Oxytocin is a hormone that we do use, and I support many children who are on it, but it is not something that I, because I'm not a prescribing clinician, can recommend or implement with a child, so I really lack the expertise to answer that well.
Okay. Has cannabis oil been used for ASD?
Short answer, yes, but unfortunately, I don't know anything about it.
Okay. All right, next one. Since eczema is an indication of internal inflammation, I'm stumped about my son that he is still inflamed, considering the fact that he has been gluten and casein-free for close to 3 months. I assumed the inflammation would have reduced by now. Why not?
We do know and we see that children who are delayed responsive, so they don't exhibit an overt allergy response to milk protein, can have a delayed response in the form of eczema or other skin conditions. So it's perfectly reasonable to assume that removing casein protein from milk and gluten from a child's diet might improve their skin condition. However, we also know there are so many other things in play at this point that other allergens could be involved, other things that could be driving that inflammatory response. So our recommendation would be work with a clinician to order appropriate testing that might give you further information on what's driving that inflammation. I wouldn't say necessarily go off of that diet if you've seen beneficial results elsewhere, but I would say keep uncovering and peeling back those layers of the onion to see what else might be driving that particular response.
How do I know if the supplements I'm buying are good or bad?
We recommend only buying supplements from a trained clinician who has vetted each of those products for you in most instances. On occasion, I can say with full confidence to a client, you can pick this up at a local retailer or a local compounding pharmacy. But my experience has been you need to trust the clinician that's recommending and prescribing that intervention, and therefore you need to trust their brand recommendations, because on multiple occasions I mean countless times we will say you need magnesium citrate or you need this multivitamin, and a family will come back in and say we didn't get that brand but we got this brand, but it really doesn't matter because it didn't work anyway. And our experience has shown time and time again that when you use the product that's recommended, that we've vetted to verify that it is free from a lot of ingredients that you don't want your children to have, and also actually has the things in it that you do want your children to have, we get good results.
What tips do you have for parents whose children are overeaters? That is, they have no natural governor to indicate when they're full.
That's a really good question, and something that we struggle with fewer children than I work with more picky eaters than I do with children who are overeaters, but we have certainly seen children with that behavioral pattern in our clinic. My first thought is evaluate what's driving the behavior. So is there any syndrome involved that could be driving the behavior that we could treat and then minimize that response? Second, I think that you need some sort of therapeutic and behavioral intervention and evaluation, because I think that the program needs to be put in place by a trained feeding therapist who can deal with it well and not in a punitive fashion, because you don't want punishment involved here. You want shaping behavior that's proactive and positive. And third, I think a medical evaluation is in order just to confirm what could be driving it. And if we get any lab results back that would allow us then to define things we could use to suppress appetite from a supplementation perspective in a safe way, or support fiber intake, for example. All of those factors we can evaluate with more information on both dietary intake and nutrient status via lab work.
Okay, and so conversely, since you mentioned it, we have a question about picky eaters. Do you have recommendations on how to get my son to eat new foods? Right now, he only eats food from specific fast food chains, certain colors, etc.
So I strongly recommend when anyone comes into our clinic and we look at types of foods eaten and also nutrient intake, that really drives for us where we prioritize dealing with food and what the child is actually eating. And on that team, there are more and more feeding therapists who are available to drive some of that decision making on, okay, how do we shift away from the pizza, hamburger, chicken nugget diet into something that's more whole and healthful. And that involves tiny, tiny baby steps for most children, but can be highly effective. So, for example, it could begin with getting the chicken nugget box and replacing it with whole food chicken nuggets, or getting the French fry container and replacing it with healthy French fries, or and it's based on a philosophy called food chaining that has been proven to be highly effective and offers some great insight, which I think you can find information on it in several books as well if you Google and look at Amazon.
Are xanthan gum, guar gums, aluminum-free baking soda, etc. safe to consume?
I think that question depends on the child. Some children can be more responsive to gums than others, and so we're cautious with those. If we're problem-solving children who are still responsive dietary-wise, that might be something that a clinician would ask a client to remove. From an aluminum-free baking soda perspective, I've never had a child who has had a response to it, and we honestly use a lot of that in our practice because we recommend cooking with it, but also I recommend its use in Epsom salt baths to mitigate any dry skin concerns from the Epsom salts themselves. And we've never really had a problem with a child having a reaction to that particular component of intake or supplemental support with the Epsom salt baths.
If I can't give him milk or wheat, and if he has other food allergies, what will he eat? Many parents ask us that question every day, and working with someone or looking at resources to help problem solve a menu, and a very simple menu plan I think is in order, because once you have that plan in place, so a meal plan, menus on a rotating basis, that can then morph to include additional components. So without knowing a child's specific self-limiting factors beyond a gluten and casein-free diet, I can say, you know, every meal can include a protein, a fruit, a vegetable, and some form of good fats, and then we can expand from there. Okay, this is a question from a parent who's concerned about infractions occurring when their child is at school. They're saying, we keep our child on a very strict diet at home. However, recently we've been seeing changes in his stool patterns that seem similar to the ones he had before he started the diet. Is it possible he could be getting infractions at school? Is that a way that we could detect them?
It's absolutely possible that it could be infractions driving your child's changes in bowel status. I would encourage both an open conversation with the school to start if that hasn't already taken place. It could honestly be that the child is getting food and exposure in the absence of knowledge of any of the teachers or aides in the classroom. But I would just verify all snacks, all treats that are brought into the classroom, and perhaps work with the classroom to see what your options are in terms of defining can all snacks be safe for every child in the classroom, which is an approach that many schools now take for peanut allergies, for example, so that if your child has a clinician's note, you could then ask that anything consumed in that classroom not contain gluten or casein. The other things you need to be thinking about, I think, are Are they suddenly starting to work with stickers in the classroom? Are there lots of stickers available? Because we know that sticker glue has gluten in it. Are they doing a component, do you have a mailbox or a post box in the classroom where the child could be licking the back of an envelope and most of that glue contains gluten? Is there Play-Doh used in the classroom, and is it real Play-Doh? Because if it is, that has a gluten base, and many children that we work with end up sneaking Play-Doh bites throughout the day, and that's one additional source of exposure that it's kind of hard to track down. So, and then once you've done all of that homework and you're still at a loss, I would say if you're working with a clinician, go in and explain this change, because it might be time to do some more investigative work and see, could there be an infection that you're not recognizing? Is the child beginning to respond to another food in his intake that needs to be removed? And could you get written support to verify dietary intake and dietary restrictions to make him more successful in that classroom?
Next question is about probiotics. There's so many different probiotics available. I'm confused. I don't know how to select one that is right for my child. Do they need to be refrigerated to be good probiotics? Should they be liquids, powders, pills? I'm baffled by how many choices there are.
There are more and more probiotic choices out there every day, and I will be honest with you and say that choosing a product, it's become much more complex because these are not a it's not a regulated industry, and so a labeled dose might not be the actual dose in the bottle. There could be contamination problems. So I would really go back to what I said earlier about working with someone who can make that recommendation for you. If that's not possible, I really think that you would need to educate yourself in terms of ingredients, because many and most probiotics are cultured in dairy, and you want to avoid that if your child is on a gluten and casein-free diet. You also want to think about various uses, because different probiotics have serve different purposes. Some are used for small bowel concerns, some are used for specific types of bowel issues. So in terms of choosing off the shelf the appropriate product, there is one product that has been studied and used over time called Culturelle or Lactobacillus GG, which has been researched and is a good starting point. The drawback is there's some ongoing concern and question if there's any casein exposure with that one. Another product out there is a Saccharomyces boulardii product called Florastor. Both of those are used in multiple research. Florastor, again, though, has lactose milk sugar in it, but is said to be casein-free. So if you're pulling off of the shelf and over the counter without a clinician's advice, those might be safe places to start, or look for versions of those raw ingredients that might be milk-free.
Okay, great. Next we have a cooking question, just to shift things up a little bit. Can you suggest healthy cooking oils and healthy cooking flours that are gluten-free? I find almond flour seems to burn easily. What about sorghum, or to bake with?
Good questions. In terms of oils, I would direct you to the autism.com website and also the Johnson Center website, which is johnson-center.org. I believe there is a webinar listed at either or both of those sites that is 90 minutes on heat points and types of oils and which ones to use for what and which ones to strictly avoid. And so given the information density there, I'll just direct you to that to answer your question, because I feel like that's a great resource. In terms of flours, we are using and recommending more and more. I understand your concern about almond flour. I tend to recommend mixing it with other flours like the sorghum or coconut flour and have less of a response to less of that burning response and that browning response that you're talking about. And I think great resources, if you haven't seen these websites, for recipes with those flours would be Alana's Pantry, which is ELANA pantry.com, and also thespunkycoconut.com.
I brush my child's teeth 3 times a day and take great care of them, but they still are brown. They look troubled. Do you have any tips about nutritional support that we can provide that will help our child's teeth?
I would strongly encourage looking at mineral status of your child so that you can confirm that calcium, magnesium, and other status is solid. I would look at working with a holistic dentist or a dentist with a natural approach who can help you think through both care options and also what might be driving that. And then there's a little bit of interesting data emerging out there that talks about remineralization and how to remineralize teeth and practice good oral health with a variety of different approaches. So I would encourage you to look at that particular approach as well.
Okay. Here's a question about yeast. This parent wants to know if there is a way to treat yeast nutritionally on an ongoing basis through foods.
I think yes. If we're talking about GI overgrowth or dysbiosis involving yeast, the best approach from sole dietary use and no nutritional support products, in our opinion, would be fermented foods. So beginning to use things like kefirs and sauerkraut and kimchi, anything fermented, any fermented milk. If your child is casein-free, you can also think about fermented coconut milk or almond milk so that you get the benefit of that good bacteria and start to suppress any dysbiotic problems.
Okay. Here's a baking question. I can find it with a label that says that it's gluten-free, organic, and nitrate-free. How do I choose the best?
I think the things to think about, if it's gluten-free, organic, and nitrate-free, all things equal, would be, do you know the producer? So is it a local farm that is not packaged, processed to get it to you? What does organic mean? So what were they actually feeding that pork? But truly, if you can find something labeled gluten-free, organic, and nitrate-free, I feel like you're in a good place for something reasonable and moderate intake that you don't need to be worrying about choosing the best of the best, because that sounds like a solid label. And if you have multiple options, I'm very impressed.
Okay. Next question. How do diet, environment, and genes interact in autism?
Oh my goodness. I think I need a long, long time to begin to address the theories there. I think that the short answer is we are just uncovering the research that's allowing us to make concrete I guess, speculation even on how these interplay, and the emergence of genomics and nutrigenomics is evolving, and to say more than that would be speaking out of turn on my part, I think, because I need a lot of time to explain the theory behind it. But if you want to know more about it, there are multiple resources that I can send your way.
The next question is about corn. Is corn becoming the new gluten? They're saying here, how can you tell if your child has an issue with corn? Is organic corn always non-GMO, or does it have to say non-GMO on the label?
All good questions. I don't think that corn is becoming the new gluten necessarily, but I do think we haven't paid enough attention to corn in our diets in general and also in the diets of our children, because it has a way of sneaking in at every meal on multiple occasions, from cereals to corn chips to casseroles to, you know, we eat a lot of corn, and for children who are on a gluten-free diet, we often substitute with corn or corn-derived products when we take that gluten out. And so many kids are corn responsive, and I think it's something that we need to be paying attention to for a couple of reasons. One, the GMO issue, I think, is pretty profound, and we recommend that any corn that is consumed is non-GMO. To my knowledge, and I've verified it several times, but this could be changing given the labeling laws that have changed. Anything that is labeled organic is required to be non-GMO in our country, but while I feel like I'm speaking with knowledge on that right now, given the shifting sands, I'm uneasy saying it will be that way, or it could have changed last week and I'm unaware of it. The other issue with corn that people are, I think, recognizing, particularly in the population of children that I serve, is the issue of mold and its response. So if you have a child who is corn responsive, it could be, frankly, the corn gluten that they're responding to. It could be the processing that they're responding to, the GMO issue, or it could be mold. And so really the only way, just like with gluten and just like with casein in our experience, that you're going to know if a child is corn responsive or not is to take it out of the diet completely and reintroduce it and monitor for change.
This parent's saying, my son has been diagnosed with PANDAS since late last spring, so for about a year. Although he's been on a gluten, casein, soy, corn, dye-free diet for 6 years, it was helping a lot, but he has restricted his eating again and is very carb-seeking. Have you seen this related to PANDAS at all, or should we be looking for something else?
In thinking through our client load and those we've served with a PANS or PANDAS diagnosis, I do have kids who have become more restrictive at varying points in their treatment from a dietary perspective. My first thought, I think, in this at this juncture would be confirming that there isn't any dysbiosis involved or any additional infectious process involved that could be layering in to complicate that diagnosis. So I would rule that out and then perhaps set up a repletion plan that included healthy carbs from completely alternative sources, but getting lots of those carbs in so that that need is met.
Okay. Here's a good one. I put my child on the diet and he got much worse. It's been terrible. We took away dairy, we took away gluten. Now my spouse is not on board and my parents are criticizing. I've tried to explain it will take more time or might take more time, but they want to know how long it will take.
I'm so sorry. I think that is a situation that we've encountered more than once, and I would encourage you that if you're not involved in a support group to join one and start working on answers in that environment, but also speak with a clinician, because from what the limited information I have really in this question, the factors involved are numerous. So it could be that it's not a totally clean elimination, and so every little exposure that your child may or may not have is exacerbating behavior and he's getting worse. It could be that you've added in something that he's responsive to, so substituting soy milk for cow's milk, for example. Or it could be that removing those two proteins has allowed his body to, or he has developed a response to a third or fourth or fifth allergen as well. And all of those things, it would be really helpful to have someone problem solve with you, because there really isn't an overt and easy answer without kind of really digging through what he's been eating on a daily basis and also what he hasn't been eating and what his potential exposures might be. So I would really say find a support group, find a clinician, and don't give up.
Okay, next question. Hi, I'm from India, and I work with children and adults on the spectrum. My question is, what are the benefits of omega-3 fatty acids? Can they be given as supplements to children? What are the natural vegetarian sources of omega-3s? Thank you.
So we're learning more and more about omega-3s, and one company, Nordic Naturals, has an entirely data-driven website out there that just tracks all of the research on omega-3s across diseases and disorders. So if you go to Nordic Naturals, you can find a link to their research library, which has hundreds and hundreds of citations in it. I think that we can safely use omega-3s in the children that we serve. There are numerous research studies out there looking at the use of omega-3s in the pediatric population. Some of those studies look at ADHD, other behaviors. Omega-3s have been researched in cardiovascular disease, in schizophrenia, and I think that barring one recent publication within the past year that created some uproar based on its interpretation, most of the research, if not all of the research on omega-3s is significantly positive. So having said all that, finding the right product is important. If you're going to use a fish oil, you need to make sure it's a clean, safe, screened oil that is vetted carefully by either someone you trust, or the company provides information on their website about their distillation and also testing process, so that you know you're getting something that is what it says it is. It hasn't been altered or ruined in the distillation process, and it also does not contain any toxins that you don't want to introduce to your child's body. In terms of vegetarian sources, the one source that we use consistently is microalgae, which provides DHA. I'm less, that's something that we use a lot, but it is it's quite an expensive product. So truly, it's something we use only with our vegetarian families who do not consume fish or seafood products in any way, because there is also another omega-3 product that's derived from mussels that we use as well.
Okay, I've got a question here about the specific carbohydrate diet. It says, we tried the specific carbohydrate diet for my 5-year-old son and saw improvements in his language. His language became much clearer. We did this for 6 months and decided to reintroduce some grains because the diet was so challenging. My son is allergic to eggs, and it was very difficult for social situations. His language regressed, and we went back on SCD, but unfortunately we didn't see the results we saw the first time. We're reintroducing grains because his digestion never improved the second time. He still has loose stools, and this improves slightly when eating grains. We don't know where to go with diets.
I would say I would confirm that when restarting the specific carbohydrate diet after reintroduction of grains, you began with an intro diet that was very limited for a period of time, which we employ for 2 to 3 days. It can be used in pediatric patients up to 5 days, but I would stick strictly with an introductory approach and not move beyond that for that time frame, as long as your child is well hydrated and eating. Because that introductory phase, more often than not, is what drives response to the diet itself. So sometimes families can slip into the diet and introduce new foods, go back to an introductory approach, and then reintroduce foods very rapidly, which may or may not be what you did initially. But when you get to this place where you've reintroduced grains, there's been a GI reaction, and you need to fix that, you really need to go back to ground zero and start all over and walk step by step through an approach, very methodically reintroducing foods and monitoring for response. If you've done that, then I would say GI testing might be in order, just to see if there's any pathogen exposure that could be treated and eliminated immediately that you're missing through the dietary approach. I would encourage you to keep problem solving specific carbohydrate diet, because it sounds like he was a responder and you've just hit a bump that we need to help you work over or around. And there are a number of resources online that I'm sure that you've found as well, and several support groups that can be highly helpful in helping you problem solve perhaps ingredients or things that you might be using now that you weren't using initially.
The next question is about allergy testing. The parent's saying, I've tested my child for allergies and they all came back negative. I don't understand why I would remove foods from his diet if he's not allergic to them.
That's a question that has layers and layers, again, of response, because our traditional allergy testing looks at antigen response on one level, which is IgE response. That's a typical allergy histamine response that is available through any standard lab. And it really truly identifies those children who have anaphylactic peanut or anaphylactic milk responses, for example. And that is what that true allergy testing is used for. Every other test that's out there, so an IgG test is another test that many physicians and practitioners will use, that looks at a delayed antibody response. So more often than not, if we have a child that presents with eczema, for example, who, as we addressed earlier, that child may show positive to several proteins on an IgG test, and that would drive which foods we would eliminate. And then third, there are children who respond to foods on another immunological basis, and also there's a celiac diagnosis. And so if the child has not had a celiac screen and is continuing to consume gluten, I think that's the third level that we would want to really look at and see from a data perspective and rule out response on all three of those levels before we said, okay, maybe dietary intervention isn't such a good idea. Having said all of that, from a rational, data-driven approach, what I tell families time and time again is, if we're creating a healthy diet for you and your child, you have nothing to lose, and our clinical experience tells us that creating a healthier diet that meets all of your macronutrient needs, so gets you all the protein, carbohydrates, and fats, and also your micronutrients, all those vitamins and minerals, you have nothing to lose if we trial this for a period of time. And you will never have to think, oh, I could have done that, but I didn't. And so, yes, we have these three data-driven questions, but we also have this, okay, go with what feels right question. And if you feel like it's something you want to attempt, we support and encourage you to go ahead and do that. Because honestly, from a clinical perspective, after treating thousands of families, we get kids who have negative numbers across the board and have a positive response to dietary intervention. And we get kids who have positive responses on those testing levels that I mentioned and really have a negligible response to the first stage of dietary change. So there's a huge component of this that we as clinicians, as hard as we're working and as hard as we're trying, haven't been able to quantify and publish yet.
The next one, this mother is saying, my child is 10 years old and cheating on the GFCFSF diet. He's tired of not being able to eat so many of the things he wants. Since he doesn't experience severe reactions like kids with anaphylactic allergies, it's hard to keep his buy-in. There's no more diarrhea or gut pain, but he still does have yeast issues. After 6 years now, do you think planned vacation day breaks using enzymes is a way to work with him? Or should I do a return to each restricted food type one at a time? Based on the infractions, I think that having a little does not affect him, but I do see behavior issues worsen if he has more than 2 meals in a row with gluten or a combination of foods and sugars. So they're asking if they can cheat with enzymes and if little diet holidays are okay.
If your child has been on an elimination diet for 6 years and he is also at a place where he's communicating that he prefers other foods, he wants other things, I would say Food is a huge battle in our society, and I'm sure there are other things that you are working with him on, and he's working hard, and I think you do have to come to some compromise as he gets older and expresses this opinion. And I would work up a managed plan with him, frankly. And either approach, which you've outlined, seems to be manageable and reasonable, particularly in light of, I'm struggling a little bit without being able to ask other questions, but particularly in light of your noted negative response after multiple exposures. I'm hesitant to say eliminating and reintroducing one protein at a time might be the way to go, only because you already know the answer there, it seems. So I think a planned exposure, while it's not my first choice and probably not yours either, but a planned exposure, so the kids at school are going out to an ice cream parlor, pick your battles, and if you know he'll take the enzymes and you know that you're prepared to deal with the response and he is as well, I think you have to have a conversation and a healthy approach to dealing with that problem.
Here's another question about fish oil. It says here, do the benefits of fish oils and other supplements work equally on a system that has not been detoxified or put on a special diet?
I think that's a question that's still out there to be answered, but in my experience, and also somewhat I think it's validated in some of the literature that I've looked at, modulating dose, so increasing dose to address maldigestion or malabsorption, is appropriate. So I think that until we have more information that tells us concretely about that issue, starting with a safe level of intervention and bumping up from there to those therapeutic levels that clinicians use can be helpful and appropriate.
I'm trying to go gluten and dairy free, but this is overwhelming. Are there quality cookbooks, websites, or instructional diet books that can really help us move in the right direction, that leads to success without too much stress?
Absolutely. There are so many resources out there for all of us now in approaching a gluten and casein and soy-free approach that we can all be successful. There are many more products that are, and product lists. Whole Foods has a gluten and casein-free list, for example, of everything in their store. So if you're someone who has to have something that has been prepared, it lets you know which Amy's Organics products, for example, are gluten and casein-free. And while I like to think of food and meals as something that my grandmother would have put on her table a long time ago, so that's whole fruits, whole vegetables, protein source, minimal complex carbs, we have numerous options. And from a food preparation perspective, there literally are, there must be over 100. I should count what our options are. But I think if you look at the autism.com website, that will lead you to some basic resources. There's also a blog on our website that lists several different books as well.
Here's another one about enzymes. So they're asking specifically, is there an enzyme or supplement that breaks down gluten? If you use enzymes, does gluten really need to be completely removed?
Yes, there are enzymes that break down gluten protein. However, from both an intake perspective and also, I guess, a data perspective, I discourage families from treating and using enzymes solely and not changing dietary intake, primarily because I look at this as I look at other disease processes. I want to eliminate what's causing the harm and replenish with something healthy. I don't want to just treat the symptoms from ongoing intake that can have a negative effect. So yes, there are enzymes out there that digest both casein and gluten protein. We encourage families, just as this recent question, if you're in a situation where it is necessary that you use enzymes because there is gluten or casein intake, I understand and appreciate and support that. If you're in most situations where you are able to completely eliminate that gluten, I strongly encourage you to do so.
Okay. This is about a 10-year-old with autism who has slowly lost weight over the last few months. They're now on a quest to gain weight. He's gluten and casein free and has been for several years, and he has a very sensitive palate. His cholesterol is low, so he's currently supplemented. He eats some vegetables, many fruits, likes his approved carbs, and he eats beef and chicken as well as some GFCF turkey sausage and regular bacon. But do you have recommendations that might help him gain weight on a limited diet?
I think there are several options. I'm wondering, I guess my first question is, do we have additional laboratory data that could speak to the sudden onset of weight loss? And if you don't have that, I encourage you just to go have a chat with your pediatrician about this. I'm wondering too, is he losing weight or is he getting taller? Because this typically is a window of time where kids can really thin out and appear to be losing weight, but in fact they're just getting taller and taller and taller. And number three, in terms of bulking up dietary intake with a selective eater, I would say yes, you have options. If he would tolerate a smoothie, that's one way that we can get a nutrient-dense meal in quickly, easily, and lots of calories. We have a number of recipes that contain 450 or 500 calories for 6 ounces of intake, and I'm happy to share those recipes, Denise, if you want to forward any contact directly to me. Also,
okay.
Using things like coconut oil alone, you can take coconut oil straight. Many people do. You can mix it in a smoothie. You can mix it in something that's been prepared like oatmeal, or you can spread it on toast. Anything that you can do, you can stir it into a stew made with the meats that he is currently consuming, and that will get a bulk of calories in as we're trying to do this over time. I think I would focus on those first two issues first, and then actively seek to add organic, unrefined coconut oil in terms of, by the tablespoon, you're looking at a lot of caloric intake, and that's where, if you can get it in, it's fairly innocuous. I think you can hide it, and then we could talk about other weight support products too in those smoothie recipes if needed.
Okay. So next question. This parent is asking, how do I find a nutritionist, somebody who has experience working with children with autism?
I think that there's information for your reference on the autism.com website. I also think that support groups can be a great source of information. You really want to be careful in choosing someone who has experience both in a pediatric population and also someone who has worked with children with autism and understands the dietary nuances that we've been talking about and doesn't look at you like you're speaking a different language when you mention a GFCF diet, for example. And I think I would look to local resources. I would speak to your physicians if you're working with a physician who treats children with autism. They might have some specific autism nutritionist recommendations. And also, just for reference, know that from a nutrition perspective, many nutritionists are allowed from a licensure perspective to work with you at a distance and provide counseling and consultation via Skype. And there are several quality nutritionists across the country who do that, and you might find their names and their contact information on the autism.com website.
Okay, here's an interesting one. This parent's asking, despite good oral hygiene, my son has terrible breath. Is there something we could be doing nutritionally to help him reduce this problem?
I would strongly encourage you to look at small bowel overgrowth, because that's typically what drives what you're mentioning to me there, and I think that means supporting getting data, if at all possible, working with a knowledgeable clinician who can get a stool sample or a urine sample and look at what might be going on there, and then you could begin to treat after you have that data, because you might need to have very specific information on what's driving the overgrowth for any intervention to be effective. But you can start using fermented foods. You could use a good probiotic, and the two that I mentioned earlier would be safe bets over the counter to start. But really you want to be flooding good bacteria in there, because it sounds like you're dry. It's that bad breath is coming from his GI tract, not necessarily from his mouth.
Do you have any insights about the connection between nutritional problems and sleep? My child does not sleep well, and we aren't finding relief through melatonin.
Okay, I would say there are a number of paths that you can try here. Thinking about melatonin as the option that works well in many children, I would say to you, make sure that you're using a time-release version, make sure that you're using a quality product, try to find something that's been recommended by a clinician, and know what safe doses are, because over-the-counter dose doesn't necessarily equate with therapeutic dose that is approved in the literature for use with or recommended for pediatric patients with sleep concerns. So that's the first thing. I wouldn't rule melatonin out as an option until you've exhausted how to use it correctly across all options. So setting that aside, I would then say talk to your pediatrician or your treating clinician about running an iron level and a ferritin status on your child. So standard blood work. We know that children with low ferritin seem to have sleep concerns. When we supplement with iron, sleep status can improve dramatically. So those are the two paths I think I would firmly address and rule out, leaving no stone unturned, and I think you would probably have good results with sleep. Finally, if neither of those works, have an honest conversation with your pediatrician about potential for a workup with a neurologist looking at latent seizures, because we do know that overnight seizures can disrupt sleep, and they don't necessarily look like a tonic-clonic seizure that you would expect. They can be subclinical that disrupt the child's sleep but not look so overt that you see them.
The next question asks, what foods can help his body recover from the use of steroids and antibiotics, since good bacteria might be killed off in the process?
So typically when a child begins a course of antibiotics here, we're supporting with fermented foods and we use probiotics. S. boulardii, which I mentioned earlier, typically over-the-counter, easily available, researched in the form of Florastor, is a good support product while on that antibiotic, and also for the duration of the dosage. The box that you have is exhausted. Typically that's 10 to 14 days of concurrent use with an antibiotic and 14 days after the completion of the antibiotic. In addition to that, you can look at replacing with the other product I mentioned, which is a lactobacillus GG, that is supportive of a variety and replenishes the GI tract. I would caution you to dose that one separately and away from your antibiotic, because it will be canceled out. You don't necessarily have to do that with the Florastor, because it has a different mechanism of action and will not respond to the antibiotics.
The next one is about vitamin D. It asks, what's a good source of vitamin D in food other than milk?
That's a really good question, and bottom line is, after many years of looking at this, we supplement because our food sources and the amount available in serving sizes that the children I work with will actually eat is negligible, and it's much easier to dose in current dosage that we have now with the products that we have. It's essentially a drop a day. So one tiny drop in a child's glass of water or in a child's mouth gets them more than enough of what they need for the day in terms of vitamin D, and if it's one less battle that I have to ask a parent to do to get a vegetable into their child's mouth or another food, I'll do it.
Okay, this mom needs breakfast and school snack help. Can you add protein powders with gluten-free flours to make muffins, and how much to 2 cups of flour? Breakfast is very difficult. He won't tolerate textures of smoothies or almond or peanut butter, and I don't want him to have meat at every meal. He's burnt out on his regular cereals. He won't eat eggs or fruit. Sometimes he will eat gluten-free waffles. I add buckwheat flour. Any new ideas?
I think, like more information on what he does enjoy to be able to speak fully to this question. I think my general thoughts would be suspend the idea of breakfast. So look at what he enjoys for lunch and for dinner and what his other meal sources are. If they're healthy and whole and complete, use that for breakfast. Don't put yourself in the box of it has to look like breakfast to be breakfast, because many of the kids that I work with end up waking up to what looks a lot like dinner, or a bowl of soup, or something savory that might be unusual for breakfast but works for them and they're happy. And we have lots and lots of thoughts available in terms of specific snack ideas and breakfast ideas, and you can find those on the blogs online. But in hearing this question, I guess without further background information, I understand the frustration. I would really think through documenting how many foods he does enjoy and what he will eat. And if he's at a threshold, so if he's only eating 8 or 10 foods, then I would really consider getting feedback from a feeding therapist who can help you expand his intake and his palate. Because if he keeps self-limiting and has those restrictions, it's going to get harder and harder to meet his nutrient needs. You asked, I think, early on about adding protein powder into any flour, and you can absolutely do that. Every powder is going to be different in terms of nutrient value and nutrient status, so I can't really give you a scoop or 2 scoops per flour or flour substitute per se, but I would say, we work regularly with families who do that, and adding a serving, whatever that serving size might be, into a single dose or a single, I guess, recipe can work up to 2 or 3. If it serves 4, then adding 4 servings of that protein powder doesn't change the texture or flavor of most recipes substantially to the point where it's inedible. But I think it's on a case-by-case basis, honestly.
The next question is about the MTHFR gene. I hear a lot about this gene, and my son has been tested, and he has it. Does this relate directly to nutrition in some way? Is there a connection between protein or other elements of the diet and the MTHFR gene?
So that gene in particular has been looked at in terms of a variety of different diseases, and it provides, it is related to the methylation process in the cells of our bodies. And one of the components that's necessary for that methylation process to be successful is folate in various forms. Folinic acid, or there are 5-MTHF is another methyl tetrahydrofolate product. So folic acid is a B vitamin. It's classified in the B vitamin family, and If your child has either one copy or two copies of that gene and you are working with a clinician, I would encourage you to talk to that clinician so you can get knowledgeable advice on what level of folate support would be beneficial for your child based on that test result and his health status. And I can't really speak to that, not knowing age, weight, size, activity level, etc. So, but I think it's definitely something to look into.
Okay, we're almost out of time, but I wanted to ask you this question. I think it's one that you probably hear a lot. This parent's saying, I have a difficult time getting my child to take his supplements. He can't swallow pills, and we have a great deal of pills and capsules that we have to crush and compound ourselves each day. Do you have tips about how to get this in without it being a daily battle?
I feel bad about this daily battle every client I speak with because it is a hurdle for us in most instances. There are the rare occasions where a family will walk in and say, yes, our 4-year-old started swallowing pills 1.5 years ago and everything's great. But most families struggle with this issue and we problem solve it on a case-by-case basis. What works for one family might not work for another, but some tips and tricks I think that we give families, and whatever you choose has to align with your behavioral programming approach if you're involved in behavioral programming and your parenting approach, frankly, because some families will just put the supplements in a syringe and insist that the child swallow them, no questions asked. It becomes a compliance issue. If the child is non-compliant and does not feel comfortable doing that and you do not feel comfortable forcing that issue and this is the battle that's escalating, other options include mixing the supplements in some form of organic baby food, so any sort of pureed food that your child will associate only with supplements is appropriate. What you don't want to do is if your child prefers pear sauce, for example, and that's a food that he takes for lunch or has at dinner time, you don't want to mix supplements in something that your child will then want and be expected to eat at another time because he will likely avoid that food in other instances and it may become aversive. But look for something that you can pair and mirror with supplements so there are 3 options and he knows what to expect there. If that's not an option, think about teaching pill swallowing. We've worked with kids who are very young and who are very successful. You can get supplements compounded into very small capsules and you can work with behavioral therapists who can teach pill swallowing just as we teach children how to eat and expand their diets. We can also teach them fairly easily how to swallow pills and remove that battle as well.